Hello and welcome to the Rural Doctors Programme. I'm Jerry Gannon. As always, thanks for your company. In this programme, we take a look at extreme temperature health hazards. But before we get into that, here's a quick word from Rural Health West's Events Coordinator, Lisa Thomas.
Hi, Lisa here from the Rural Health West events team. Our next conference in Perth will be the Aboriginal Health Conference on the 7th and 8th of July at the Pan Pacific. This year we've got an engaging number of keynote speakers coming along to the conference to present, including Mark Wenatong, who is currently the Senior Medical Aboriginal Officer at NACCHO in Canberra, and also for his work up in the Cape York Peninsula with the Aboriginal Medical Service up there. Another keynote who will be presenting at the conference will be Debra Cheatham. She's an Indigenous opera singer who has done some fantastic work over East. She will actually be performing at the conference and also be giving a recital address. Also in the program are some clinical updates, skills workshops including ultrasound skills. There'll also be some joint injection workshops available for delegates to attend. We also will be hosting a CPR workshop for those of you that need to upgrade your current skills in that area. You can check out the provisional program on our website. Go to the Education to Conferences to Aboriginal Health and you'll see further details there. This conference has tripled in size in the last couple of years and it is now the leading Aboriginal health conference in Western Australia. Registrations are now open and we would love to see you in Perth in July.
Thanks, Lisa. Now let's get into the program, and we're going to take a look today at issues to do with the body's response to extreme hot and cold temperatures. Later in the program, we'll speak to Dr Abby Harwood, who's done a number of trips to the Arctic and Antarctic as a ship's doctor. But right now, Olga Ward is joined by Dr Ian Rogers and Dr Scott Teasdale.
Scott and Ian, welcome to the program.
Thanks.
Well, I guess being from up north, Scott, you don't see a great number of hypothermic patients, but I think it's commoner than we would anticipate, and certainly not all patients who've been lost in the snow for 12 hours. Have you seen anybody who's had a cold problem?
I was in Karratha for 12 years and I can't recall many hypothermic cases from there. So I don't have a great experience in that area, but Ian, I think, encounters that reasonably frequently.
Yeah. I think, and it always surprises my colleagues from the eastern states that someone in Western Australia is interested in hypothermia, but because I used to work in the eastern states, I think I actually see more hypothermia here in Perth than I used to see in the eastern states.
So what kinds of situations would you see? Like, I was thinking about people who work in, refrigerated environments as much as anything, or perhaps people who've been wet and injured themselves, which is why I was asking you, Scott, falling off a cliff in Karajini or something.
Yeah, I didn't have personal experience with that, but I believe that there have been some quite cold people pulled out of the gorges.
I think they're the sort of the healthy person in an unhealthy environment group, and they're the ones that get celebrated and talked about and hit the news. But they're actually uncommon in comparison to the unhealthy people in what we would think are healthy environments. So for us, it's often the elderly who hit the ground for some reason. They've fallen, fractured a hip. Sometimes they've only fractured their wrist and they don't have the strength to pull themselves up, or they've had a stroke or diabetic hypoglycemia. So there's often a concurrent medical or trauma problem that's caused them to collapse. In summertime, of course, they collapse with their air conditioning on and no one finds them for 6, 12, 18 hours, and it actually gets quite cold. And then, of course, in winter time, if they do the same thing, a lot of people in Perth don't have heating in their houses. So they collapse and the same thing happens. It actually gets quite cool at night time. So we see a surprisingly large number of hypothermic patients in Perth, but most of them are those older patients with an underlying cause.
So this is something we should really be thinking about if we've had a patient, say, brought in by ambulance who's collapsed at home and we're not sure how long they've been collapsed at home.
Absolutely.
You routinely kind of take a tympanic temperature, but are there any other clues that would say, well, gosh, I should think about it?
It's interesting, you say we routinely take a temperature. It's the fourth observation that so often gets forgotten. Everyone remembers to take a pulse measure of blood pressure.
Because they're not febrile,
yes.
you say...
You stop thinking about it. And I'm surprised how often I've seen people where the temperature didn't get taken initially, because it's not necessarily the first thing you think of in someone who's collapsed.
How do the thermometers, the ear thermometers?
The infrared tympanic thermometers.
What sort of levels do they read down to?
They actually read down to any level. They're actually very accurate in the sense that they will measure the temperature of your tympanic membrane. One of the problems with them, though, is that they're designed to operate in a certain ambient operating temperature range, which is basically room temperature. So varies from device to device, but it's about 15 to 28 degrees Celsius, the sort of temperatures that people would tolerate in a house. So you can't use them out in the field when either it's very cold or it's very hot. So if you, and we've done these studies, we've taken thermometers and put them and a person in a car baking in the sun so that the car gets up to 55 degrees Celsius to see what it'll tell us the person's temperature is. And it'll tell you the person's temperature is 43 degrees Celsius, but actually their temperature is still 37 degrees Celsius. And the opposite happens too. We put some people in the freezer at the hospital at minus 20 degrees Celsius, the walk-in freezer, and left them there for a few minutes with a thermometer. And the thermometer will tell you that they're profoundly hypothermic, but they're not. They've got absolutely normal core temperature. So the answer to your question is they're really accurate if you use them in a healthcare.
So using them within the hospital.
Yeah, using them within the hospital,
fine,
and they track the temperature really accurately. They're actually a really good tool.
So we
for
don't
that.
need to find the old rectal thermometers or anything else like that anymore?
Well, no, except in the most critically ill ones. We would certainly get out the rectal thermometers for the sort of semi-conscious.
What about
in these days, of course, we have electronic ones. So most of the standard monitoring systems have electronic probes that can just be left in place.
Yeah.
So, like, if you were suspecting that a patient was hypothermic and they'd come in after this collapse, how hypothermic is hypothermic? What sort of core temperature are we talking about here?
Well, we classify hypothermia into mild, moderate, severe. A core temperature of, normal core temperature, of course, is 37. Mild hypothermia is usually 32 to 35 degrees Celsius. Moderate is 29 to 32, and severe is under 29. The coldest I've seen of a person who's alive was 23.7 degrees Celsius. The lowest temperature I think ever recorded that someone has survived with accidental hypothermia was 13.8 degrees Celsius. It was a Norwegian doctor who fell through a snow bridge into water and was immersed in ice cold water to her neck. And she's now back practicing medicine after being arrested for an hour or two. So we really start to worry when the temperature gets under 32 degrees Celsius. When
but
you
you
get
wouldn't
to that
kind of get
range.
your knickers in a twist if it was 35.1 or something.
No.
And if you are warming somebody up, practical ways of doing this in a country ED where you don't have those nice warm air blanket
the
things?
nice forced air rewarming blankets. They're great things to get the women's auxiliary to buy you, though, because they look impressive. There's a machine you can put a plaque on top and they don't cost too much.
Yes.
The forced air rewarming blankets are the best evidence-based way of rewarming people. There's no doubt about that. But of course not everyone has those. I think people often forget that most patients are actually capable of rewarming themselves if you remove them from the environment where they got cold. So, if someone's brought in from home, you take them out of the wet clothes that they're in. You put them in a warm, dry, wind-free environment with some blankets, and they'll rewarm at 1 degree Celsius per hour. And there's no great hurry about it. There's no evidence that rewarming people fast improves their outcome. So that's what we call passive or endogenous rewarming. That's rewarming yourself. And letting them shiver too. The other thing, the most effective way of rewarming is shivering. And some people often want to suppress the shivering because shivering's unpleasant, but shivering gets you warm. I think the other part of that that's often forgotten with endogenous rewarming is that the energy substrate you use to rewarm yourself is glucose. These people have often depleted all their glucose or glycogen stores if they've been there for hours or they've been stuck out in Kurrajini National Park for a while. So you've got to give them some glucose either intravenously or just warm drinks. It's not actually the warmth in the drink that matters, it's actually the sweet bit of the warm drink.
So the tea with 2 sugars and a slug of brandy was...
probably not the brandy bit, but certainly the sugar and the...
Well, on that, if you do give someone some brandy, then they vasodilate.
Yes.
Does that then speed up their warming if you had a warming blanket on them?
It speeds up their loss of heat.
What if they have a warming blanket, so you've now got them in a warm environment?
No, it doesn't. It's still... The other thing too is it blunts your hypothalamic response to cold. So
even once you've taken them away from the cold environment, you still can't give them...
And that's why people have a shot of brandy or something when they feel cold, because it stops them feeling cold. It doesn't actually make them warm, it just stops them realising that they're cold.
if you've got somebody who's semi-conscious and you're giving them intravenous glucose, is 5% glucose just sort of running at a...
Yeah, you'd be amazed how much energy you can get out of 5% glucose running at, you know, a litre over 2 hours or 4 hours, because they tend to be a bit volume deplete anyway, so they can do with the fluid. So you don't have to give them high concentrations of glucose, but even that small amount of glucose in 5% dextrose meets a lot of their basal metabolic requirements.
Can you heat the IV fluids?
Yes, yeah, but heating the IV fluids doesn't actually transfer heat.
Yeah,
it just stops them from getting cold, because most fluid rewarding devices warm them to about 42 or 43 degrees Celsius, but by the time it gets through the IV line into the vein, it's down to body temperature. There's been a few scary studies where they've used super hot IV fluids given into central venous lines, you know, at sort of 65 degrees Celsius, but I don't think we should do that.
In other words, instead of just giving them cold IV fluids out of the shelf, you
yes.
can heat it. So for a rural ED that doesn't have a coiled warming device, how else can you heat that? Can you microwave it?
Have you tried microwaving it? Yeah,
well,
it works. It works.
That's
you can.
what set the fire alarm off at Swan Districts last week. So we had a half-hour delay at the theatre.
I have tried to do that, and I have had that discussion with the nursing staff about whether or not that's
the concern is, as anyone would know who's heated up just a dish of anything in a microwave, is that microwaves don't heat very evenly. Yeah. So if you are going to, it needs in a sort of standard powered microwave, a litre of fluid gets to the right temperature in about a minute or a minute and 20 seconds, but you probably need to do it in 20-second bursts. Take it out, shake it all around, and then what you can do is you can wrap the bag around one of those electronic thermometers and find out what temperature it actually is before you pour it to the patient, because you wouldn't want to find out it was 58 degrees or something. So you can do it that way. The other thing that a lot of people have is they often have some warm IV fluids in their operating theatres. You know, there'll be a sort of a cupboard in the operating theatre somewhere, even in small places.
Or even, very small places. Yes. And I'm thinking of the last swag of hypothermic patients that we had who rescued a baby out of the bottom of a swimming pool in July in Southern Cross. And one of the older nurses said, I will go and turn on the warming cupboard, because of course we used to have maternity and we still had a warming cupboard.
Yes.
And she was the only one who knew where the on switch was, but that certainly gave us a lovely supply of warm blankets and warm fluids.
I always find that fascinating, because the nurses always rush to put warm blankets on patients who are hypothermic. But warm blankets actually don't rewarm you as well, and in fact they probably make you cool down a little bit, because they inhibit shivering, which is the most effective way of generating heat, and they tell your hypothalamus that your body's getting warm, don't try to rewarm yourself. So they probably don't need you can give the warm blankets to the nursing staff for night shift.
Or to the mum who's just sitting there shivering with dripping wet hair.
And just put normal blankets on.
Right.
What about those crackly silver things?
Silver things.
Those, the emergency blankets.
Well, they often
that
come in
fold
the ambulance offices when they pull them from the field. They often have that warming.
Do they actually do anything?
Well, they came from. They're a NASA thing. They were, they're called space blankets because they were developed for use in space. And the theory is that they reflect infrared radiation. But of course, someone who's really cold doesn't radiate any heat anyway. Right. So they actually don't work in the way people think they work, which is to reflect heat. But they work because they're windproof and waterproof. So they create a vapour barrier so that the air around you is fully humidified, so you don't get any evaporative heat loss, and they protect you from the wind, so you don't get any convective heat loss from...
So a big plastic sheet would do exactly the same.
A big plastic gar bag would do exactly the same thing. So a lot of rescue people, bushwalkers and so forth, would just carry a big gar bag and they just cut a hole in the top, pull it over the person's head. Yeah. But the great thing about space blankets is they're so neat. I mean, they fit into no space at all. Yeah. The other thing we love about them is that it tells us every time someone's pulled all the blankets off, because you hear the noise, which means you can put all the blankets back on again.
And when you've got a patient, say, who has collapsed for whatever reason with hypothermia, is there any advantage to keeping them relatively hypothermic?
That used to be... That advice used to be out there a lot. There used to be a fear of rewarming people too quickly. There's no evidence that rewarming people quickly is a bad thing, but there's actually no evidence that rewarming them quicker is any better than just rewarming them slowly. But there isn't any advantage to keeping them cold. What you want to do is to get them into that safe temperature range where they're not going to get cardiac arrhythmias, which is the thing you fear with that's what you die from in hypothermia, is your heart stops, you become asystolic, or you go into ventricular fibrillation. So these days our advice is, if you've got a way of rewarming people, do it. And if you haven't got a way of rewarming people in the field, at the very least be really careful to minimise any ongoing heat loss. So that's, you know, dry clothes, vapour barrier, wind-free, warm setting rather than a cold setting, warm the IV fluids rather than giving cold IV fluids.
Clearly though, if they've gone into cardiac arrest from being hypothermic, how successful is your CPR and your advanced life support in a patient who's asystolic, or how effective is defibrillation in someone who's in VF because of hypothermia?
Well, the answer is the outcome from cardiac arrest and hypothermia is much better than you'd imagine.
Yes.
We talked before, but we can talk again briefly about this. There's a really celebrated case that I was involved in treating, and I can use his name because it was all in the press and was well known, was Yiftach Aloni, who was an Israeli lifeguard who was over here for summer and decided to do the Rottnest Channel swim. Everyone in Western Australia wants to do the Rottnest Channel swim at some stage in his life. His stroke became very uncoordinated at about 15 or 16 kilometres into the race, and his support crew got really worried about him. They dragged him out of the water, and he arrested as they pulled him out of the water. They started CPR straight away. They got a defibrillator on a boat to him within 90 seconds or 2 minutes, and he was in asystole, and we've actually got the computer trace, the backup traces to confirm he was asystolic. It took them about 20 minutes to get him to Rottnest Island where we were, and so we met him on the jetty, and I honestly thought he was dead. I mean, my first instinct was, well, he's dead. He's asystolic, he's got no pulses, he's got no respiration, fixed dilated pupils.
But they're not dead until they're warm and dead.
No. And his core temperature, much to the horror of some of the people who were around there, I actually pulled out a rectal thermometer in the middle of the resuscitation. His temperature was 29.5 degrees Celsius. And we were actually able to resuscitate him. In fact, with some adrenaline, we were actually able to he spontaneously went back into slow atrial fibrillation. So he survived at least 30 minutes of documented asystole. And a week later, he was discharged from hospital, essentially neurologically intact. He could juggle 3 balls, he could speak 3 languages. My son said to me, well, he probably used to be able to speak 4 languages and juggle 4 balls, but I mean, to all intents and purposes, he was neurologically intact. Now,
it's quite encouraging to know that your CPR works sometimes, isn't it?
And I think, but what it highlights is that hypothermia protects your brain, and in the end, it's your brain that determines, the damage to your brain is what determines your outcome in cardiac arrest. So you're actually much more likely in hypothermia to end up with an intact brain at the end, because the brain is protected. And what had happened to him was that he had got colder and colder swimming across to Rottnest. His support crew had picked just the right time to get him out of the water, but he had a cool brain when his heart stopped. So you asked the question about defibrillation. Defibrillation doesn't always work in those really low temperatures.
So you just have to make sure you continue uninterrupted
CPR and try to rewarm them until you get them. And basically what we do is we try defibrillation at each temperature, and if it doesn't work, we just try to rewarm them by a degree and then have a go at it again, and if that doesn't work, go again. But you might be talking a few hours of CPR in someone who was significantly hypothermic before you give up.
So given if you're doing CPR, clearly there is an urgency to get their temperature up then.
Yes, yeah. So then you've got the problem of how do you rewarm someone who hasn't got a circulation.
Yes.
And in the big hospitals in Perth, we'd put them on cardiopulmonary bypass, but that's not a very useful answer in Karratha or Lake Grace or wherever we happen to be. But what you can do is you can put a chest tube in. You put an intercostal catheter in the left side of their chest, and you can pour warm tap water into it. That's actually one of the most effective ways of rewarming people. You warm the water, you put water in at about 42 degrees, which is water that feels hot but not scalding hot. And you can, I mean, yes, you can warm the IV fluids if you can find the nurse with the, who knows where the power switch is for the rewarming cupboard, but you could just pour warm tap water in. You pour in 1.5 litres, 2 litres, and then let it all drain out. And then that'll rewarm them at 5 or 10 degrees Celsius an hour. Because you're delivering the heat exactly where you want it to go to, which is to the heart, which you want to start. And if it starts, it's then going to circulate that heat to where you want it to go.
So given they're doing CPR, come across to the side, put a chest tube in and just pour water in.
Just pour warm water in.
I suppose you're in desperate states.
Well, they're dead.
Yes.
You know, so they will die without.
So if
you've got a young dead patient, you might as well have a go.
Other cold injuries, do we see many of them in Western Australia? You know, things like frostbite and things like that?
Oh, look, we sometimes see frostbite from sort of industrial accident, you know, sort of people who haven't followed the rules in a refrigerated plant or something like that. But they're normally pretty good about that sort of stuff these days because your boss doesn't want you to get frostbite. That's going to cost him a lot of money in workers' compensation. We see a bit of chilblains in bushwalkers, canoeists.
What's the difference between
people who live in
chilblains
Southern
and
Cross?
what is actually chilblains?
Well, true frostbite, of course, is the tissue's actually been frozen, at least briefly. Chilblains is a sort of near-freezing injury, and it tends to be a repeated heating, cooling sort of thing. So you almost freeze, and then you get a bit warm, and then before you have a chance to get properly warm and repair all the damage from the cold, so it's a repeated cycle.
So these are people who work outdoors, farmers.
Fishermen, farmers.
Especially fishermen, I guess, because their hands are wet, but farmers, you see this quite often. They usually just come in when the itch is driving them mad and they're starting to peel the skin off the back of their fingers.
And unfortunately, you can't do much for them except tell them to be more sensible about it.
Don't
Don't do it. It's the treatment's largely prevention. So chilblains is that sort of above freezing but repeated cold injury, and probably repeated cold injury without the time to recover properly.
What about the other people who are particularly susceptible? I'm thinking about diabetics with poor circulation or patients with Raynaud's. Anything special that...
No, I think it's just avoiding situations where they know they're going to get too cold, and then when they feel their hands have got too cold, making sure they rewarm them properly before they go back to do something again. And you mentioned farmers. I could imagine exactly with the farmers. They've got a job that they've just got to get done, and they're just going to get it done no matter what. That would be the sort of attitude, wouldn't it?
Yeah, and they just stick their fingers in their armpits for a little while and then get going.
Back at it again. So, and frostbite. Look, not over here. No. You know, you'll see occasionally over in the eastern states. You might see someone who's come back from Nepal, who's had a frostbite injury, but.
And finally, speaking about places like Nepal, the other thing general practitioners do see very often is patients who are going off on the great adventure travel, and they're going to climb Mount Everest or Kilimanjaro or even Kosciuszko in the middle of winter, or they're going skiing. Or
I think they appreciate the risk of cold. They understand that, and of course, the people who have the financial wherewithal to go to those sort of places usually have the resources to buy the right equipment to minimise their chance of cold injury.
And besides, it's so nice to have the new gear to show.
Yeah, that's right. That's part of it's the shopping ritual before the trip, isn't it? But I think the bit they don't appreciate is the risks of altitude illness, particularly if they're going on a guided tour. Most of the trekking companies, for instance, are very careful about doing as much as they can to avoid altitude illness. But if they're self-guiding or they're picking up some guides while they're there, they're not always as smart about that sort of stuff. So altitude illness is is something most of them will never have experienced, won't have any concept of at all, and it's something that we can talk them through before they go and give them some advice and guidance.
So at what altitude do people start developing symptoms, and what sort of symptoms do they usually get first?
You can get altitude illness at anything above about 2,500 metres, so a little bit higher than Australia. You could get it in New Zealand,
so
but you'd
sort
be
of
on
8,000 odd feet.
8,000 odd feet. In New Zealand, you'd be on the top of a pretty serious mountain. You know, it would be a mountaineering expedition. But visiting places like in North America, in Colorado, Nepal, obviously, Kilimanjaro is a classic for causing altitude illness because it's so easy to get up so quickly. So anything above about 2,500 metres, which interestingly is the equivalent pressure that they pressurise commercial aircraft to. Because obviously they couldn't fly you at an altitude in planes that would induce altitude sickness.
No, I imagine that our cardiac cripples and our COPD patients aren't going to be running up Kilimanjaro, but what about asthmatics who are young and relatively fit?
Look,
do they run into more problems?
They're obviously at risk of precipitating an asthmatic event because in that cold, dry environment. So as a general practitioner, you'd want to be giving them reinforcing all the standard advice about proper use of their preventative medication. You'd want them to have stuff with them to take if they did actually develop an acute exacerbation, so they've got some sort of treatment plan because they can't ring an ambulance or
Absolutely.
pop down to the GP or the local
Down to the
hospital.
chemist and get some more prednisolone.
But with altitude illness itself, it's interesting that there's not a lot of pre-existing medical illnesses that predispose to it. And interestingly, it also, being fit doesn't prevent you from getting altitude illness. It's an idiosyncratic thing. Some people will almost never get altitude illness, and other people always get altitude illness once they go above a certain altitude.
Mm-hmm.
So us unfit people walking up a hill are quite used to being hypoxic, so we cope with it just as
well.
well.
The major manifestations of altitude illness relate to cerebral edema.
Oh yes, yeah.
So I get altitude illness, and I always tell people that's because I've got a really big brain and it's so tightly packed inside my skull, but I don't know if that's true or not. Certainly the much older people are less likely to get altitude illness, probably because they've got a little bit more space around their brain to accommodate a degree of cerebral edema. So I think you certainly need to warn them about the potential for altitude illness. They need to learn about it beforehand. And
Do you give them Diamox to take with them?
Look, what I give them in particular is advice about ascending slowly and carefully. I wouldn't recommend that anyone routinely takes preventative medication unless they've been to that altitude before and they know they're going to get symptoms, because you don't know who's going to get the symptoms and who's not. Taking some acetazolamide, some Diamox with you might make sense. Taking some nifedipine to treat high altitude pulmonary edema would make sense. Having some dexamethasone available to treat high altitude cerebral edema would make sense. But the other medication that actually works, interestingly, is sildenafil. So you can use all of your impotence drugs to treat high altitude pulmonary edema as well. So would I give patients most of those things to take with them? I'd really want to know that
It's rather a comprehensive list
Yeah,
for someone. You'd really want to know that.
You'd want
something.
somebody who was kind of semi-medically qualified, or at least a registered nurse or something.
The best advice is prevention, and the best prevention is slow and gradual ascent with acclimatisation.
And we'll return to that discussion in a moment. Dr Abby Harwood is a Kununurra-based GP who's been a ship's doctor on numerous expeditions to the Arctic and Antarctic. She talked with us about the types of medical circumstances she encountered and how her experience as a rural GP prepared her for relative isolation.
Back in 2001 and 2002, I did 2 consecutive trips on an expedition ship down to Antarctica, and in 2002 I did 2 consecutive trips up through Alaska and into Siberia as ship's doctor. It was pretty amazing because they're expedition ships, both very small. So the one down to Antarctica only had around about 50 passengers. The one going up to the Arctic was around about 100 passengers, and they only use basically volunteer doctors on working holidays. The equipment available on board can vary quite dramatically. For example, the Antarctic expeditions that I did, we only had 1 bottle of oxygen, which was about 4 hours worth, and we're running polar diving trips. So that was a little bit interesting and a bit stressful. Obviously, one of the big factors is weight when you're travelling by aircraft to get there. So trying to find out before you go what's available and then having a think about what you might need to take with you is a really good idea. The most common complaints are colds and coughs and sore throats, and then seasickness is the other thing that you see quite a bit of. In a lot of ways it's the same as dealing with morning sickness. It's eating small amounts frequently, distracting yourself by making sure that you keep busy and getting fresh air. If you're hanging out down in the engine room and not eating anything, yeah, you are going to get sick. Whereas if you get out on deck and get some fresh air and make sure that you are eating small amounts frequently to keep your stomach settled, then things should be okay. I try to avoid drugs myself because I find that most of the seasickness drugs make you drowsy, and that can be a big impediment if something happens. And I also find that if I use something, then it takes me longer to adjust. That's just my personal thing. Whereas if I stick with it, for the first, knowing that for the first day or so I might be feeling a bit yuck, then things are okay after that. The Antarctic trips, I had one crew member and one passenger with sore backs. Both of them actually had extruded discs because of the movement of the ship, etc. They'd hurt themselves. In the end, the crew member I had to send home because we just couldn't treat it appropriately on the ship, and what he really needed was rest, and that he was still required to do his watches, which were 4 hours every 12 hours, which really wasn't helping his recovery at all. The first thing I always do when I get onto a ship or into a similar situation, say somewhere remote, is find out what other options I have available to me. So it's a case of talking informally with everybody else, just sussing out who's got what qualifications with first aid. There might be other doctors around. For example, the second Antarctic trip I went on was with a group of people who had quite a lot of, had very extensive wilderness experience. Most of them were wilderness first aiders, which meant that they could deal with almost anything. And that was the only reason that I allowed myself to learn how to ice climb on that trip, because I had to consider if I fell and broke my leg, then what would happen? And I knew that there were other people around me who could deal with that situation if it arose. Plus, they could also deal with the other situations that would arise on the ship with that particular group of passengers. Whereas the first trip that I did, there was no way I was going to do anything that might put myself at risk, because there were quite a few passengers on that trip who were at considerable risk themselves and potentially could need a lot of medical intervention. It's important to try to get a list of the drugs on board before you go, because they're sourced internationally wherever the ship's been. So often there'll be drugs that we're not familiar with in Australia, or the names might be slightly different. So giving yourself a chance to look up what they are and how they work before you go. From the point of view of personal gear, clothing is incredibly important. Much better to take multiple light layers that you can layer as opposed to big, thick, heavy things. So for example, I think there's a photo there of me all geared up, and at that stage I was wearing probably 6 layers coming from summer in Karratha to Antarctica, and I had thermals plus polar fleece plus the protective outer waterproof layer and a couple of other layers in between. Always wore 3 pairs of gloves. So I had thermal gloves covered with polar fleece gloves, covered with waterproof gloves over the top. You know, to press the button to take a photograph, you can't do it with 3 pairs of gloves on. So you've got to take 2 pairs of gloves off and you've only got 1 layer on. And my hands would actually start to cramp up from the cold, and I couldn't actually physically take the photo, and I'd have to put the gloves back on, warm them back up again, and then go back to take the photo again. So from the point of view, if you were trying to resuscitate people on land in those conditions, I think it would be absolutely awful. I personally would put them back in the Zodiac and get them back onto the ship as quickly as possible where you've got equipment, and also better ambient temperatures, because it's just almost impossible. Also taking into account that everything in the Antarctic at least is rocks. So you'd have somebody lying on a whole heap of rocks whilst you're trying to resuscitate them or whatever. It would be much better to get them into the Zodiac and get them back to the ship and then continue from there. The companies that do these types of trips do prefer Australian rural doctors for their trips, because we can make do with basically nothing. Generally, we can take nothing and still treat a patient. Obviously, that's not ideal, but you've got to remember that you don't have an ICU sitting there waiting for you if something does go wrong. I think also generally Australian rural doctors deal with uncertainty a lot better, and with that isolation and and having to cope with maybe keeping somebody alive for 3 or 4 days before you can get them back to other facilities. On the Antarctic Peninsula, we were 2 days by sea from Ushuaia, so if anything happened, it was a case of we would have had to stabilise and get them 2 days back to Ushuaia over the Drake Passage, which is incredibly rough. And if you speak to any of the cruise companies generally, they would preferably take a remote Australian GP over anyone else in the world to work on their ships, because we're just better skilled and better prepared for dealing with emergencies and having to think a little bit outside the box. I definitely recommend to other people to go. It's a really enjoyable experience. I suppose what you've got to remember though is that it's not a holiday and that you're there primarily as ship's doctor and not as a passenger on holiday, and so it is actually a lot of work, and you'll probably come back more exhausted than when you left. I suppose the example is that on the trips up through Alaska and up through to Siberia, I would be up and out by 6 every morning out on the Zodiac scouting the landing sites with the expedition leaders in order to assess whether it was suitable for some of the passengers to be able to get off and go and do whatever the day's activities were. So by the time you've done that for 3 weeks straight, you are pretty tired at the end of it.
And thanks to Dr Harwood for taking the time to speak with us. Now let's return to the discussion with Olga Ward, Dr Ian Rogers and Dr Scott Teasdale.
I thought we might go to the other extreme and talk about heat. And one of the terms that I've heard bandied around both by patients and medical staff is heat stroke and heat exhaustion. What's the difference? What are they?
Patients always want to have heat stroke, don't they? You get more street cred if you've got heat stroke. Heat stroke is rare. It's a true medical emergency, and the defining sort of criteria for it are a core temperature over 42 degrees Celsius and an altered mental state or some sort of neurological abnormality. Most people who think they've got heat stroke haven't got that at all.
Yep.
They've got dehydrated, which is what heat exhaustion is. Heat exhaustion is essentially dehydration associated with exposure to heat. I mean, you must see a lot of that sort of stuff up in Karratha.
We did, when I was working in Karratha, we did see a reasonable number of patients with that, often in the unacclimatised patients,
yes. Yep.
Of which, of course, with the fly in, fly out workforce is more common. And I was endlessly surprised by some of the outdoor workers about how much water they actually drink or how much fluids they drink in a day.
And how much is enough? Like, you know, I've had patients complain to me, oh, but I've drunk 3 litres in my 12-hour shift, and I'm like, well, you probably needed about 6 or perhaps even more.
Look, this is actually been a key research interest of mine for many years. We've got this whole new illness called exercise-associated hyponatremia, which didn't exist before the mid-1980s. And it's basically due to excessive fluid consumption in the setting of exercise. And it was because a lot of people were trying to drink to rules. They were told, you've got to drink this much, this much and this much. And if you're an Ironman triathlete, you'll do anything to improve your performance. So you just keep drinking to the rules, drinking to the rules. But similarly, if you're working on a mine site and the mine site says you've got to drink that much and the supervisor says, look, you're not drinking enough. So it's not a good idea to drink to rules. The best rule is simply to drink when you feel you need to drink. Because surprise, surprise, human beings are actually capable of managing their own fluid balance so long as they're given adequate access to the fluids that they might need. So drink ad libitum is the message, when you feel like it.
And is water sufficient?
The sports drink industry would like you to believe that having lots of salt and glucose in it would make it better. Pepsi-Cola and Coca-Cola, who own all the major sports drinks brands, will make more money out of that. That's why I was saying this is an illness that didn't appear until the mid-1980s. You know, if you don't drink, you die. We all see the ads on TV from elite sportsmen telling us how you've got to drink this, you've got to drink that. The answer is yes, water probably is okay, because sweat doesn't contain anywhere near as much salt as you imagine. And if you are acclimatised, your sweat actually contains even less salt. That's part of the acclimatisation process, is you gain the ability to sweat more easily in bigger volumes with less sodium. So they actually produce quite a hypotonic. So a little bit of salt replacement's not a bad thing. The good thing about sports drinks is probably mostly the glucose is in them, which is, improves athletic performance.
So if you do have a patient with hyponatremia,
yes,
that's because they've drunk too much water rather than they haven't had enough salt.
Because you can't drink enough salt to overcome the excess fluid because a sports drink's got 20 millimoles per litre of sodium in it. Your body's 150 millimoles per litre of sodium. So you can't really compensate for the excess fluid consumption by supplementing salt. But true heat stroke, which I said is a much rarer condition, probably isn't just about hydration. A lot of the cases of heat stroke, there's other mitigating factors. And some of the sort of things you've got to think about in mine sites is people abusing stimulants, which definitely can increase heat production and decrease your ability to dissipate heat because they inhibit sweating and so forth. Another group is patients who are on psychotropic medication. So some antidepressants, antipsychotics, any ones with anticholinergic side effects will decrease your ability to dissipate heat.
Quite a lot of them make you sweat a lot more.
Yeah,
too,
some of them certainly make you sweat more. But and then look, part of it, there's probably some sort of genetic predisposition to it as well. There's something strange about how their muscles couple and uncouple and move calcium around and so forth. It's not well understood.
So what's actually happening there when they've got heat stroke?
Well, essentially what happens when you get heat stroke is you get runaway heat production. Your hypothalamus, which controls your temperature, has got so hot or control has been lost of it that it tells you to keep generating heat when you no longer need to, and doesn't tell you to dissipate heat when you desperately need to as well. So, we see, in the city, we see heat stroke in people who use psychostimulants and go to an all-night party. But I suppose you could see just the same thing in a mine site, and if it happens to be 50 degrees Celsius as well, and you're not drinking
and they're
enough.
not sweating when they come in really hot?
Yes, well, true classic heat stroke, they're actually not sweating.
They're dry.
Yeah, they're dry.
And hot,
But we do see people who are sweating who've got heat stroke as well. There's two forms. There's exertional heat stroke and classic heat stroke. Classic heat stroke's the sort of thing you see in old patients in nursing homes who are on drugs with anticholinergic effects, whereas exertional heat stroke is the athlete.
Yes.
True heat stroke is actually quite uncommon, but it's one of those true medical emergencies. I mean, you've actually got to the temperature where your proteins in your brain are coagulating. You're boiling an egg. Your brain is an egg and it's being boiled and it's going to set, and you don't even want it to get soft boiled. You'd like it to remain liquid.
So how on earth do you treat that in a hurry? Do you pack them with ice packs, cold packs,
well, I'm interested to know what you guys do, because they must have, in places like Karratha, they must have considered how they're going to do that.
Well, when I think of that definition, I probably never dealt with a true heat stroke. You have a lot of people with heat exhaustion who are dehydrated, and you reckon we just fill them up with cold IV fluids, and they're in a cold environment in the air-conditioned hospital. So, I haven't really considered how. I suppose I would pack them with ice, but I don't know whether that's effective or whether it actually makes them shiver and because they've reset their temperature.
Well, we take different approaches in different settings. In major sporting events, they will often use ice, and they actually have those small children's wading pools full of a whole, because sporting events have always got ice everywhere. There's drinks everywhere, so there's ice everywhere. And you'd literally just lie the person in an ice bath. Now, we used to think that might be a problem, that it might make them shiver or that it might make them vasoconstrict and hold all the heat in centrally, but that is such an overwhelming cold load that you're imposing that works. Now, we don't do that in an ED. In the emergency department, we would usually use evaporative cooling. So if you've got one of those clever rewarming blankets, you can actually just put it on cold, sponge the person first and put it on cold, or if you haven't, you just get someone with a big piece of cardboard to start fanning them, or just put two big pedestal fans on the patient and then sponge them with tepid water. If you use cold water, they might shiver, or at least they'll pylo-erect. So evaporative cooling, it's exactly the most effective adaptive heat loss mechanism we've got is sweating, is evaporative heat loss. So you just maximise their evaporative heat loss. So
that's more effective than ice packs on the groin and things?
Ice packs on the groin and in the neck and in the axillary, that's a sort of secondary part of it, but the evaporative cooling is actually the most effective. And
I think what I've seen is, cold wet towels just being kind of recycled with a fan on the patient. That seems quite effective.
Yep, it's pretty effective. The evidence behind that evaporative cooling comes a lot from Saudi Arabia, from the Hajj, the Muslim pilgrimage, where a lot of they have a lot of people with true heat stroke, and they actually have portable heat stroke units that because everyone's moving along together, and they just use evaporative cooling. So they have sort of portable units that can spray people with water and fan them at the same time.
If we come back to hyponatremia, so hyponatremia from excess water intake.
Yes.
How does that present, and how would you treat that?
If it's mild, it just presents with non-specific symptoms
like confusion.
Or just nausea and headache and general malaise. And those symptoms don't often stand out because often these people have been doing things that would make you feel that, you'd expect to feel that way anyway. You've just done an Ironman triathlon, or you've just spent 10 hours on a mine site. If it's more severe, it's the neurological manifestations that we worry about. So confusion, ultimately seizures, coma, because they get cerebral edema from the fluid shifts associated with the hyponatremia. And that's a life-threatening situation when we see that. But that's nowhere near as common as the milder form. And the milder form will self-correct. If you just take them out of the environment they're in and tell them to stop drinking, they will just pee all of the excess fluid out.
Yeah. Now, for some places where there isn't an on-site lab and you're kind of trying to make a clinical diagnosis, is there any pointers or, can you...
Look, the symptoms, and I've treated a lot of people with exercise-associated hyponatremia. The symptoms are so non-specific that without a lab to give you a sodium result, you can't be certain of the diagnosis.
So if someone's just got some vague symptoms, a bit confused, and you do their sodium, and you don't treat a specific number, you just go on their symptoms?
On their symptoms. So if their sodium's 129 and they say, I've got a bit of headache and I don't feel well, you say, well, don't drink anything and you'll get better. Okay. And you just watch them and they just pee it all out. But if their sodium's 129 and they're confused and ataxic and a bit twitchy, then you give them some hypotonic saline.
Okay. So you just go on symptoms, and clearly seizures would be an indication for
absolutely.
hypotonic saline.
It's an absolute. Because you've got to assume that these people were healthy before and had normal sodiums before they started.
Yes.
And hypotonic saline is the accepted treatment?
Yes, 3% or 20%. But you don't need a lot. You actually only need enough to switch off. The problem with these people is they have inappropriate antidiuretic hormone secretion, so you've got to switch off their ADH secretion with the hypotonic saline and just bring their sodium up a little bit so that they're outside of that critical range where they're at risk of fitting.
Are there any special settings where we might not immediately think about excess heat exposure as being a contributing problem?
I've been caught out a few times. One is seizures. You get someone with a seizure disorder and you assume that it's their seizure disorder again, but of course so it's sometimes when you've got a person who's got a plausible reason for fitting or an altered conscious state, and the heat stroke has complicated that rather than the primary problem. So I can think of one patient in particular who had a prolonged grand mal seizure in a car park in summertime wearing black clothes. And it took us a while for us to click that his core temperature was 43 degrees Celsius. And I'm certain his core temperature was not 43 degrees Celsius when he fell over in the car park. But then, of course, he had prolonged seizures, which is almost certainly due to heat stroke. And what he needed was rapid and aggressive cooling and then treatment for his seizure disorder.
So I guess you might also see that in patients who, as you say, who've had a car accident and maybe been thrown clear and cooked there for a few hours.
And we saw that awful situation a few years ago in the police transport, the divisional wagon of the poor gentleman who died, and that's another example. Someone's been put in an environment that they can't escape from that puts an abnormal heat stress on them. So, that obviously wasn't an underlying medical illness, but I think sometimes you get caught out when the focus becomes the underlying medical illness and not realising that heat stroke can be a complication. It's not always a diagnosis in itself. It's a complication of many diagnoses.
Do you have any special problems with kids and babies?
Well, they're at risk in both ways. They're less able to lose heat. They're more able to gain heat. Their behavioural responses are different. They've got different body mass, surface area. Yes, so they're more at risk of both. But as we were talking before, of course, they, particularly in the setting of hypothermia, they're the group where you get those unexpected survivors. You know, the paediatric near drowning in the cold backyard swimming pool. Because they can cool down so quickly, they can cool down their brains quick enough to protect them when their heart stops in a near drowning setting.
But for instance, a child left in a car,
yes,
would they be more prone? They'd be more prone to the heat injury.
Yes, yes. So they're less able to dissipate the heat they're being exposed to, and they're also less able to make the necessary behavioural adaptations. If we were sitting in a car, it was too hot, we'd get out of the car.
Yeah.
When you do try to cool a small kiddie off if they've been in that kind of situation, is there anything in particular should be aware of?
No, they're pretty easy to cool down. As anyone who'd done a bit of obstetrics out in the bush would know, it's not hard to get a child pretty cold pretty quickly, a neonate pretty cold pretty quickly, because they've got a much bigger surface area relatively, so they're actually going to be able to dissipate heat if you help them much more easily.
Do they survive heat injury better than adults?
Yes, they do. They actually do better both with heat injury and with cold. As children do in a whole lot of critical illnesses, their brains are, they still have growing potential, adaptive, they have growing potential still, don't they?
Yeah. I guess the other situation that we do sometimes see, and we're now seeing more often, is people who are setting off on the Great Australian Adventure and decide that they're going to drive the Canning Stock route or, you know, go for a long adventure trek. Is there any very specific advice that you give them in terms of...
I suppose one thing that I always am absolutely amazed at with people travelling around is that they don't get a letter from their GP before they leave home. They don't take their usual medications with them and they have no idea about them.
Can I have some more of those white tablets that I take for blood pressure,
and
please,
of course,
Doctor?
They end up in a rural community which is short-staffed for medical facilities, wanting all these things done. The other thing is, I'm often absolutely amazed at the people who go around Australia, the couple that go around where the wife doesn't drive. And so the husband has his stroke and gets shipped out by RFDS, and the wife's stuck there with a caravan and four-wheel drive.
Or creates,
not to do with heat.
Creates a potential difficult... that's almost not having a rescue plan in a way, isn't it?
Yeah.
You know?
So off track, because it's not... I don't have any specific stories about heat exposure, but they're in an isolated environment and they've got few resources. So I suppose they're at risk.
Yeah. Do you have any particular recommendations for first aid kits?
No, I don't myself, but I ended up accumulating quite an extensive first aid kit just for myself for driving, because I think it's quite an interesting topic, what a doctor should have in their car when they travel long distances in the country. I think that's an individual decision, because some people would just have a basic first aid kit, whereas other people would feel that without a few extra things that we're capable of using, that you feel quite useless being faced with a situation where there was something you could have done but you don't have anything. And there are long distances, and if you happen to, for instance, be driving in the country and you encounter a rollover, or you're camping at a remote campsite and someone has an anaphylactic reaction, what can you do as a doctor if you don't have any of the things that we take for granted in our normal work situation?
I've tackled this issue quite a few times, and I've thought about exactly the same issue. You know, what would you want? What would you feel terrible that you couldn't do as a doctor? And anaphylaxis is a classic one. It'd be awful to watch someone...
Adrenaline and analgesia, I think.
Yes, adrenaline and analgesia. I think the other thing is some basic airway management tools, and I don't mean a laryngoscope and a set of endotracheal tubes, because if anyone's ever tried to intubate someone in daylight, they'd realise that that's very difficult anyway. But for instance, as an emergency physician, I actually carry a laryngeal mask airway in my first aid kit, thinking if I meet a rollover and someone has got obstructed airway with head trauma, then being able to put an LMA in, and even if I have to turn to someone and say, look, now I want you to breathe 6 times a minute into that tube, you know, I don't have a bag mask with me, but I've got the laryngeal mask airway.
Whereas I've got Goodell's and just one of those seal masks that you can put a squeeze bag on.
And I have a pocket, and obviously I have a pocket mask
pocket
as well.
Leerdale
yes.
with a one-way valve.
But I think if you're only going to carry one drug, I'd carry adrenaline.
Yes,
Because it could save someone's life with anaphylaxis. If you really pushed, you could treat asthma with it. And then the next step up is the analgesics, I think. Local anaesthesia.
Yes, if I look back at the things that I've used, I haven't had to use the adrenaline, but certainly that was high on my list. But I have used my local anaesthetic and sutures and Steri-strips and things like that.
Well,
and I've used a Foley's catheter, etc. So.
Just remember the adrenaline goes out of date really quickly. It doesn't last in your car first aid kit. Wound closures, of course, is really important. I think if you're only going to take one piece of something to manage wounds with, I'm a big fan of the open weave adherent dressings. So Mefix or Fixamal or all of those.
Got a big tube of that.
Because you can almost do anything with that. You can treat a burn with it. You can treat gravel rash. You can cut it into strips and use it as Steri-strips. Fix a broken tent pole. You know, it fixes just about everything. So.
Do you guys have any final messages or sum up messages for the doctors about either heat or cold injury?
Well, I'm going to pick a cold one and you can pick a heat one. How does that sound? So,
sounds fine.
I think with the cold, the most important message is don't forget the basic passive rewarming as a treatment. So the basic, take off the wet clothes, put them in a warm, dry, wind-free environment and allow them to shiver and rewarm themselves. That's the basis of treatment.
I think that from our discussion today, I'll stop calling things heat stroke and just call it heat exhaustion.
Unless they are heat stroke.
Unless they are heat stroke, because as I said, I think that is much rarer but a medical emergency. And of course, for both hot and cold, remember to take the temperature. Just ask for that temperature.
Fantastic. Well, thank you for your expertise and thanks very much for joining us today.
Thanks.
And thanks to all our guests for their time on this month's programme. Now, if you're interested in issues of remote and isolated practice and exposure to the elements, then keep in mind the Rural and Remote Retrieval Conference that Rural Health West hosts each year in May at Karijini National Park. This conference provides you with the opportunity to learn about the management of medical emergencies in a wilderness environment. The residential conference takes place over 4 days with eco-tent accommodation provided at the famous Karijini Eco Retreat. Now, the conference is strictly limited to 30 delegates and the 2012 conference is already fully subscribed. But if you'd like to be part of this conference in 2013, email the events team at events@ruralhealthwest.com.au to express your interest. We'll be back on the 5th of June with the programme looking at fancy tests and procedures. In the meantime, thanks for joining us. I'm Jerry Gannon.